My dear friends, seniors, colleagues, good evening, everyone. Thanks for joining the session. Since already more than 50 people have joined, I'll just go live because we need to respect the people who have joined earlier. So the recording, anyhow, people are recording, and we can use this recording for re-telecasting into our group, and let the other people who has not joined can benefit from it. So today we will be taking an interesting session. That is, we'll look into, until now we were looking into the rate, rhythm, and axis. And from there on, we move to the P wave, PR interval, and QRS complex. So now we'll move on to the next session with the ST segment. So the ST segment is between the end of, see, this is the ST segment. It is at the end of the QRS complex, that is the S wave, final wave, to the beginning of T wave. So this is the only thing we are going to look into is today. So that carries most important. Whenever the patient comes with chest pain, this ST segment is the one which gives you a diagnosis of what we are dealing with. So now I'll go back to the basic. Whenever there is going to be a P wave, we call this P wave as the electrical activity of the atrium, that is atrial depolarization. Once the electrical activity happens, then mechanical activity happens. So electrical innervation of the atrium, once atrium is electrically activated, mechanically it has to contract and eject blood into the ventricles. This is what the atrium does it. So this electrical activity of the atrium is inscribed in the ECG as P wave. The PR interval between from the end of P wave to the beginning of QRS complex in the PR interval is the AV nodal delay. And once during which time the atrium is emptying the blood into the ventricle. During which time, after which the atrium has to relax. The relaxation happens after this area, which is seen in this within the QRS complex. Because ventricle is more powerful and the QRS is much taller, we won't be seeing any repolarization of atrium. So that is the reason why P wave only depolarization is seen and repolarization of QRS complex is not happening, because QRS is very powerful and ventricle depolarization is happening at the time. So similarly, like the atrial depolarization, where electrical activity of the atrium happens, and this is followed by the mechanical activity, which ejects the blood from the atrium to the ventricle. The QRS complex stands for the ventricular depolarization. This is the electrical current which supplies the ventricles. So this is the electrical current which is supplying the ventricle is the QRS complex. QRS complex is only 2 small square in width because the conduction happens through the specialized conduction system, bundle of his right bundle, left bundle, from there on into the Purkinje fibers, which conducts very rapidly, so that all the ventricles appear to contract at the same time. Because it is contracting at the same time and in unison, the stroke volume is very high and the cardiac output is maintained. So this QRS complex is the electrical activity which is happening in the ventricle, and ventricle is getting filled. The pressure in the ventricle is trying to increase because the aortic valve and pulmonary valve are closed at that point of time. The isovolumic contraction we call, it is increasing the pressure because electrical activity is activated. Increasing the pressure. Once the aortic pressure is exceeding the aortic valve, aorta, it opens the aortic valve and the pulmonary valve. So this time between these two, from the QRS complex electrical activity to the opening of the aortic and pulmonary valve, there is nothing is happening within the ventricle. Ventricle mitral valve is closed, aortic valve is closed, and nothing is happening. Only pressure is generated. This gap is the ST segment. Now you understand what is ST segment. This gaps in this area where electrical activity is there, mechanical activity is starting, after which the aortic and pulmonary valve is open, and this is there. Once it is open and ejects the blood out, then there is going to be a relaxation. This is relaxation is the ventricle repolarization. Now you understood ventricle repolarization is happening. That is the T wave, right? This is the ventricle depolarization is the QRS complex. Between the ventricular depolarization and ventricular repolarization, that is current acting on it and the current withdrawing. So both of them is the, between these two is the ST segment. Now we understand ST segment. What is ST segment? ST segment is the interval between depolarization and repolarization of the ventricles. ST can be evaluated by using a reference, both the PQ and TP segment. Why it is TQ and PQ? So there is an isoelectric point. See here. This is the QRS complex, P wave. And there is a PR interval. And there is a T wave. And the next QRS complex comes like this. Right? So what is this TP segment? This T from this area to this length. This is the P. This is the TP segment. This TP segment is taken as the isoelectric point, or to some extent that's P. Following the P, sorry, to the beginning of Q, you have a PR segment, PQ segment, we call. So this PQ segment or PR segment is also taken as an isoelectric point. So anything above this, you call it as ST elevation. Anything below is called as ST depression. Now you know why ST, how we call it ST elevation, ST depression. The ST segment should be in same line as the TP segment or in this PQ segment. It should be in same line. If it is not there, if it is elevated, we call it as ST elevation. If it is depressed, we call it as ST depression. Most of the time it is holding good, but sometimes in pericarditis situation like this, something there is an involvement of the PR segment also, we need to rely only on the TP segment, right? Now we know why, how do you calculate ST segment? What is ST segment? Between the depolarization and repolarization of ventricle is ST segment. This is very, very important in your diagnosis of chest pain. How do you calculate the baseline? Baseline is calculated from the TP segment or the PQ segment, right? So now I will come to this. See here in this picture. Now you are seeing this ST segment. This is the TP segment which is there, or the PR segment. Now above which, this is the bottom line, isoelectric line. Above which it is called ST elevation, or below which is called ST depression. How long this ST segment, how long the ventricle depression between these two activity, how long it will take? It takes only less than 2 small space. So in ST segment, less than 2 millimeter in chest leads. And ST segment not more than 0.5 millimeter limb leads. That is it. It's a smooth transition, very smooth transition. So very smooth transition, less than 2 millimeter in chest leads, less than 0.5 millimeter in limb leads. So now you see ST magnitude of the ST segment, how it is there. It depends on the QRS. QRS complex tall means it is also tall. Sometimes, normally also ST segment can be there. That is the point. So the commonest cause of ST elevation is non-acute domain. It is not acute domain. So it can reach up to 3 small squares. Most are in chest leads. And in sometimes in precardial leads, up to one small square also, most of the time it will be elevated. I'll come to the condition. So normally also it can happen. That is one carry-home message. The next carry-home message is how does this current of injury happens? Usually, the ST elevation happens only when there is a epicardial involvement more. So I'll tell you why this is happening. I'll make it very simple. All currents, I told you always, from the, it will be always positive when it is coming from the, it is conducted towards the electrode, will be negative when it is away from the electrode. This will make you simpler. When it is epicardial, from the endocardium to epicardial, it is current is conducted. You are placing the lead on the chest leads. So when it is there, it is toward the electrode. I will make it very simple. There will be ST elevation. Whereas in case of unstable and non-ST elevation, more of injury happens in the subendocardium. So it is acting towards the current of injury. It is away from the electrode. That is the reason why ST depression happens. Now we understand why ST elevation happens. I'll make it simple. There is multiple theories. This is the simplest of theory for you to understand. How do you calculate this ST elevation? There should be some point of calculator. See here, this is the baseline. PQ segment, or this is the TP segment, above which we call it as ST elevation. Where is the point? After the QRS complex, between the junction between the ST segment and the T wave, you have a wave called T wave, J wave. This J wave, which should normally present here. J wave should be normally here. From there on, there should be a smooth elevation like this. This should be the normal ECG looking like. Here, you are having the J point, which should be normally here, is elevated. So, this is how you look into the J point elevation, and this is how you look into the ST segment elevation. Now you understand the ECG. Simple J point elevation, that is at the end of the QRS complex, you are supposed to have a J point here, and it should hug the baseline, and then gradually for 2 small square, and then gradually have a ST segment which is going up, smoothly taking up, and it should come down as a T wave. Right? This should be the normal happening. If it is not there and the elevation is happening, especially 1 to 2 small square after the supposed to be the end of QS wave, then you call it as ST elevation, J point elevation. So now I want to make much more pakka. How do you want to see? See, I'll show you. You just draw a parabola. Say it's a continuous half circle or quarter circle, you can call it. See here, P, the PR segment from the descending limb of the P wave, you just draw a line, and if you happen to see, the line will be smoothly merged and there won't be any disturbance in the smooth line. This is the way normal ECG will look like. But in case of ST depression or ST elevation, you can see in case of ST, this will be smooth. In case of ST elevation, it will be like this. In case of ST depression, it will be like this. See here, a simple ST elevation and ST depression, 2 things will happen. Simply, one, the smoothness will be taken out. There won't be any smoothness. There will be a step up or step down. If there is a step up, you call it as ST elevation. If there is a step down, you call it as ST depression. Now you know what is here. So now you have to understand why ST, why I am concentrating only on ST segment is simple. If you understand this, acute MI becomes very simple. So what are the causes of ST elevation? Having known how it comes, we'll see what are the causes of acute ST elevation. You know, everybody knows acute MI is the common cause. But what other causes? It is not the only acute pericarditis can cause ST elevation. A simple early repolarization. You need not have a routine ECG can have ST elevation. A bundle branch block can have a ST elevation. A left ventricular hypertrophy in the ECG can have ST elevation. A left ventricular aneurysm, Brugada syndrome, hyperkalemia. So many factors will be there causing ST elevation. So now we know it is not only acute MI, there will be some normal and abnormal causes, pathology, which can mimic ST. Now we have to differentiate between an acute MI. This acute MI is emergency. Rest all not emergency. So we have to see. Generally, ST elevation, it can be spontaneous or exercise induced. There is going to be a coronary spasm. Then you call it as principal angina. The ST elevation may be transient and coming back normal. Patient can have a chest pain during which ST elevation will be there. When you see the ECG, patient will not have a ST elevation. The history will be classic. Typical pain. Then the smoker, typical pain. ST elevation is there. But we are not seeing it because at the time of we seeing there is no chest pain, ST is normal. Then at the time, if you are lucky, at the time of chest pain, you see ST elevation. When the spasm release, ST elevation cancels out. So this is how the coronary spasm will look like. And most of the time, we are dealing with the organic stenosis of the coronary artery, which can cause ST elevation MI, impaired lymphatic function. So this is how the transient ST elevation will happen like this. See here in V1, V2, V3, V2, V3, V4, there is a ST elevation during chest pain, and suddenly after the chest pain is relieved, you have got a normal looking ECG. This is how the coronary spasm, that is principal angina, will look like. So not every ST elevation is permanent. So there may be a transient. So there is another carry-over message for you. So history is very important. You have to ask the patient, smoker, young age, typically patient has a severe chest pain, typical of acute MI, and after that 15 minutes or 20 minutes, it is completely relieved and the patient is happy. And again, it recurs. So you have to catch the ECG during chest pain. So carry over message for you. So now, coming to the main, ST elevation as part of acute MI. So way back in 1920 itself, they found out. It is 1 century back, they found out that their ST elevation is part of acute MI. So MI alters the electrical charge on the myocardial cell membrane and produces an abnormal current flow. That is the reason there is an ST elevation. So another reason for ST elevation. So again, I emphasize ST segment should be compared with the TP segment or PR segment to know whether ST segment elevation. So that is again, I emphasize the J point. At the end of QRS complex, you have the J point. J point will be elevated or depressed, right? So you have to look at 1 to 2 small square from the J point for consistent ST elevation, right? So how do you look at and take a diagnosis when there is going to be a chest leads? When it is significant, when the ST elevation is more than 2 millimeter, it is significant, right? Another carry-over message. In chest leads, more than 2 millimeter, significant. In limb leads, more than 1 millimeter is significant, right? So this is another carry, because several, if you are understanding the basics, then it becomes an easier job. In chest leads, more than 2 millimeter, in limb leads, more than 1 millimeter, right? So more importantly, it should be present in the contiguous leads. So you expect V2, there is ST elevation, means it is not in V6, another ST elevation. V2, V3, V4, it should be contiguous. It should occur in the same arterial territory. Then only you call it as ST elevation. If there is one ST elevation V3 and ST elevation lead 3, you don't call it as ST elevation. This is something which is a local current abnormality due to some fault in the machine or something like this. Even though we think ST elevation is the commonest cause, it's the main feature of acute MI. Most of the time, only 50 to 70% of the time, ST elevation is there. 30 to 50% of the time, first ECG will not show ST elevation. That is the reason why we always take ECG for a typical chest pain after 1 hour. So now again, I insist, when first ECG may not be giving all clues about what is happening within the heart. That is the reason why we take serial ECG after 1 hour. If there is no chest pain, after 6 hours, and troponin after 6 hours. This is how the serial ECG and troponin has to be measured. If the first ECG is not showing changes, take it after 1 hour. This is how you, if you are suspecting acute MI, take it after 1 hour. So persistent complete occlusion of the artery will cause ST elevation. So how do you differentiate ST elevation MI from other causes? So there are hundreds of causes may be there, but the simple common causes we will discuss. Magnitude of the elevation we have to see. So when there is more than 2 millimeter elevation, that I told you, that means straight away, possibly we are dealing with an acute MI. The other condition may not have more than 2 millimeter elevation. So magnitude of the elevation we know. Then we look into the morphology, distribution, voltage amplitude, QRS width and other features. This is how we differentiate from an acute MI to risk. So we know magnitude, more than 2 millimeter ST elevation, think of acute MI. Morphology of the ST elevation. See here the morphology, ST elevation, this is more than 2 millimeters happening. Everywhere you see more than 5 or 6 millimeters there. More than 6, 7 millimeter, more than 6, 7, 10 millimeter, more than 10 millimeter. See here the ST segment, more than 2 millimeters. Here it is more than 7, 10 millimeters is there. So when there is going, variable shape may be there. There may be, see, more than 7 millimeter, variable shape, convexity upwards. There is a presence of Q wave, only horizontal ST elevation, anything may be there. So this is ST elevation. Concave upwards. Then how do you look into convex? I am telling concave, convexity upwards. In my explanation also, I always say convexity by concavity upwards during the ECG in the ECG group. So this is how you take about the convexity and concavity. From the J point to the peak of T wave, you draw an imaginary line. If the ST segment is above it, we call it as convexity. If the ST segment is below it, we call it as concavity. If the ST segment is above it or in the line, going in the line, it is due to acute MI. If the ST segment is below it, it is not acute MI. Right? Another carry home message, simple message. A imaginary line from the J point to the peak of T wave, a imaginary line, below it, concavity upwards, less likely acute MI. Above it, most often acute MI. Now you have another carry home message. So this is a typical ECG. How do you differentiate from an acute MI with a early repolarization? Young age, bradycardia, these are the basic features. And you have a J point, a distal notching or slurring J point. And you draw a line. See, I am going to draw a line. From the J point to the peak of T wave, I am drawing a line. See here, the ST segment is below and is curving upwards. This is called concavity upwards. Right? ST elevation appears to be ST elevation. See here, this is the TP segment. TP segment. There appears to be a ST elevation. 1 or 2 millimeter ST elevation is there. But ST elevation, even though it is present, just because it is concavity upwards, see here, not only every lead is concavity upwards. So this on site of this type of ST elevation is concavity upwards, bradycardia, young adults, you call this as early repolarization syndrome, right? Concavity upwards. So this is, even though the patient may have a routine ECG, come with a cholecystitis, everything will be there, this ECG will be there. So you need not panic about this ECG. You just draw a line. If it is below it, right, it is not acute MI. You can be confident when the patient is not having typical chest. Right? So ECG characteristic, ST elevation is not more than 2 millimeter. That is one point. That is magnitude of the ST elevation. Concavity of the initial portion of the, so concavity upwards. The distal slurring or notching or slurring of the terminal, that is the J point slur is there. And the concordant T wave, large amplitude, T wave will be large, but you did not panic. So it is present in most of the leads. It is not respecting the arterial territory. So that is most important. So it may be present everywhere. It may be present in V2, V3, V4, and also in lead 2, lead 3, AVF also. So what does it mean? It is not respecting the arterial territory. So this type of diffuse ST elevation and ST elevation is not more than 2 millimeter, very 1 or 2 minuscule ST elevation, concavity upwards. we call it as benign early repolarization, right? So this is the typical ECG. See here this ECG. I'll take this segment. See the line which I am drawing, below which is the ST segment, which is concavity upwards. So even though there appears to be ST elevation, see here, this is the line which we are talking, and there is a 1.5 millimeter ST elevation. ST elevation, J point is elevated, and there is concavity upwards. Now you can clearly see, understand why this ECG, even though it appears classic, ST elevation, everything is there, we need not panic. It is a simple early repolarization. So the prominent part, J waves, concave upwards, relatively tall and frequent symmetrical T waves, occasionally inverted T wave also can happen there. So tall R waves in the left precordial leads, young individual, bradycardia will be there. So these type of individuals, this is what is called early repolarization, and this ST elevation is benign. You need not panic. So another way of distinguishing this ST elevation is distribution. See here, every arterial territory will have the particular lead ST elevation. If we happen to see LAD, anterior LMI typical V2, V3, V4, is the only pin. Anteroseptal MI, V2, V3, V4. This is the only area it will be there. This is the anteroseptal MI. So V1 to V3. The extensive anterior MI will cover V1, V2, V3, V4, V5, V6, 1 AVL. Everything will be there. And inferior MI, you have 2, 3 AVL. See here, if it is respecting this territory alone, then we think it is arterial. That is my acute MI. If it is not respecting this, there is a ST elevation V3, V6, and lead 3. It is not correlating. It is not congruous. It is not continuous leads. So that means that it is not going to be acute MI. It is something disturbance with the electric ECG machine. So you have to understand this. If respects the arterial territory, then we call it as acute MI. Next different diagnosis in ECG is patient coming with a fever. Most of the time we tend to take ECG in private practice because the patient has some atypical chest pain. So this type of ECG, see here, look into this pericarditis ECG. ST elevation in 1, lead 2, lead 3, AVL, AVF, V1, V2, V3, V4, V5. Everywhere it is ST elevation. So you cannot have a global ST elevation. That is my one point. Patient cannot live with global ST. That means that completely all arteries are infarcted. So it means that nothing is flowing and patient will not come to you. Patient will be dead by the time the patient comes to you. So that cannot happen. So that is one point. And again, this ECG also, see, look at the ST segment. I am drawing the J point is elevated. I am trying to draw a line from the J point to the peak of T wave. See here, everywhere I am trying to draw a line, and everywhere the ST segment is below the line and it is concavity upwards. So it means, again, it is not acute MI. So it is distribution-wise, it is present throughout the QRS complex. All leads are ST elevation. So it cannot happen because with the acute MI, global ischemia, patient will not reach home because no blood supply to the heart, patient is dead. If it is happening, if ST elevation everywhere, pericardium is surrounding the whole heart. So it will be everywhere ST elevation means it is pericardium because pericardium is surrounding the whole heart. And to support it, see here, there is a concavity of J point elevation, concavity upwards. So it is not acute MI. So ST elevation pericarditis, concave. Acute MI, it is flat or convex. In pericarditis, diffuse. Everywhere it will be there. Acute MI, territorial. Here again, PR segment depression can be there. The ST segment is elevated, PR segment is depressed in pericarditis. Whereas in acute MI, you don't have anything in PR segment unless there is a atrial infarct, which can cause a PR segment elevation, and QA in acute MI. So pericarditis in acute MI, ST elevation followed by a T wave inversion, which will be a rapid evolution. Whereas in pericarditis, after the settling of ST segment, only T wave inversion happens. See here, this is what the pericarditis, there are a lot of stages are there, which is easy to understand if we are more going into the depth of it. There is ST segment elevation will be there for first 2 weeks. After that, there is a normalization of ST segment. Then T wave inversion happens. 1 or 2 months, 2 weeks, 3 weeks later on, you will find T inversion. This T inversion is not ischemia. It is part of the pericarditis staging. Then it resolves. So this is how it happens. PR segment depression happens in ST and ST elevation is happening. This is a typical case of pericarditis. After settling of the ST segment, you have T wave inversion after 4 or 5 weeks. This is what the stages of pericarditis. So now, two non-cardiac acute MI ECG I told guys shown for ST elevation, pericarditis and early repolarization. How do you differentiate between these two? Both demonstrate initial concavity of upsloping ST segment, right? That is, draw a line from the J point towards the apex of the T wave. That concavity upwards is there and it is below the imagined line. PR segment depression in pericarditis, which will not be there in early repolarization. So STT ratio, when the ST segment ratio is more than 0.25, when the ST segment to the T wave is more than 0.2, whether the ST segment much more taller, it is pericarditis, and it is lesser than 0.25, it is much lesser. It is early repolarization. These are small things which can differentiate between these two. Another ECG, 2 days back also, one of my friend referred this patient for Brugada syndrome pattern. So typically the patient has got a ST elevation only in V1, V2, not more than that. So it is not V2, V3, V4 is contiguous. V1, V2 is not contiguous. That is most important. So you cannot, two adjacent leads, why not take it as acute? I mean, it's not. V1 is separate lead. V2, V3, V4 is the anteroseptal lead. So V1 and V2 is two separate leads. When you have only ST elevation with an incomplete RBV pattern, we think it is Brugada pattern. This is because there is a epicardial endocardial difference in the electrical activity, which is part of electrical abnormality, which can cause ventricular fibrillation and sudden cardiac death in young individuals. This Brugada pattern ECG should prompt you for further diagnosis with a cardiologist, but only thing, you not panic as an acute MI. I'll show the ECG. ECG is always pattern recognition, nothing more than that. If we happen to see V1, V2 like this, incomplete RBV, looks like a RBBV, ST elevation is there, and it is not happening. See here, Brugada pattern. So if it is happening like this in V1, V2, then you think only there is no chest pain, atypical pain, suddenly comes with this pattern. So especially with the fever, you take ECG, this type of pattern will be there. You need not panic unless there is a fasting family history or sudden cardiac death or resisted sudden cardiac death in the history. So a syncope in the patient, you need not worry about this ECG. The pattern may be there in the society also. Now you know what are the causes of ST elevation, but it's not acute MI. So many factors are there, which is not acute MI. Moving on to the next way of differentiating the acute MI with the non-acute MI ST elevation. Based on QRS width. When the QRS is wide, it means there is a bundle branch block. Following the QRS, I'll just draw a QRS here. If there is going to be a wide QRS complex like this, whatever may be the terminal, this is the terminal QRS complex, terminal phase of QRS, the T wave will be opposite to the QRS complex. This is what will be there. Normally, whenever the QRS is wider, the T wave will be ST segment and T wave will be opposite. Simple. Right? So when there is going to be a left bundle branch block, in lead 2, I'll tell you, lead 2, it will be like this. It will be like this. So here, it will appear there is a ST elevation. It will appear there is a ST elevation lead 2. Because in QILBV, it will be like this. Whenever there is a QRS is wide and there is ST elevation, then we have to think whether it is an acute MI or not. There is also a criteria for it. So there one gentleman called Scarbosa proposed this criteria. See here, ST elevation more than 1 millimeter and concordant QRS complex. See here, you take V2. there is a RBB. Normally, it should happen like this. TVA inversion. But if the same RBB, it is like this, and instead of TVA inversion, there is a elevation like this, then we think it is an acute MI. So this is what is the first statement says. ST elevation more than 1 millimeter and concordant, the same side as the QRS complex. QRS complex, every T wave should be opposite to the QRS complex. This is what when the QRS is wide. If it is in the same side, then we think it is an acute MI. Same way, in case of LBVB, normally we lead to like this, if it is there. Instead of in this place, here you have a LBVB and you have, instead of elevation, secondary STT changes, you have a STT. Instead of going up like this, there is something is coming down instead of going up. So ST depression more than 1 millimeter in V1, V2 in LBVB, we think it is an acute MI. See here, ST elevation more congruent. In case of RBB in LBB in V5, V6, if it is happening like this, or in case of LBVB in V1, V2, if it is happening, ST depression, same side if it is happening, then it is abnormal. If there is going to be ST elevation, previously I told you, when there is ST elevation, see here, it appears ST elevation. But how many millimeters should be there in case of, if you want to diagnose acute MI, it should be more than 5 small squares. Then only you call it as acute MI. More than 5 small, see here, more than 5 millimeters, 5 small squares. The same side as the QRS complex, ST elevation, ST depression as the same side. If negative QRS complex, ST depression there, you think it is acute coronary syndrome. Positive QRS complex, ST elevation is there, you call it as. Or opposite side, it is there, it should be more than 5 millimeters. See here, the QRS complex is wide here. From there, here it is up. Wide QRS complex, same side you have ST elevation. In QRS complex is negative, more than 5 millimeter, 5 small squares. More than 5 small squares, ST elevation is there. So 2 criteria are there to say it is an acute MI. There's simple ECG where you had a wide QRS complex. Now you see the ST depression. The terminal negativity is here. It is predominantly QRS is negative. But we expect the QRS to be, the ST segment should be like this. But instead of that, it is having a ST depression. So when you have ST depression like this, you expect a upright QRS, ST depression, then you call it as primary STT changes, and this is what will happen with the acute MI. So there is ST elevation is there, ST depression is there, then you call it as an acute MI. Same side, similar side. This is the Scarbosa criteria with which you are there. So the second thing is prominent electrical forces. So you know the third one to differentiate between acute MI and when there is a wide QRS complex, ST elevation is more, you call it as an acute MI, and more than 5 millimeter, same side of QRS complex, either elevation or depression, you call it as an acute MI. When the prominent, how do you differentiate between a ST elevation MI and electrical? See here, left ventricular hypertrophy. Simple left ventricular hypertrophy or something like that is happening. See here in V5, V6. There is a tall R wave, secondary STT changes secondary to the left ventricular hypertrophy. What is happening in V1, V2? See here in V1, V2. There appears to be some sort of a opposite side, positive forces. V1 is there. There appears to be a positive forces. See here, this is the TP junction. There appears to be a ST elevation. There is appear. That is because of the left ventricular hypertrophy. Here again, you will not have the convexity. You will again see the concavity. So everywhere, whenever you are seeing an ST elevation, look for concavity up, convexity upwards or smooth flattening ST segment. If it is concavity from the imaginary line from the J point to the ST at peak of T wave, you think it is secondary to left ventricular hypertrophy or LBVB or early repolarization or pericarditis. So see here the concave in LVS. That is most important. The words are very important. Concavity, then you think So the carrying of message is, whenever there is ST elevation, look for convexity upwards or flattening. If it is not there, all other ECG ST elevations are likely to be non-acute, right? So to conclude this session only on ST elevation, it is more important because you diagnose ST elevation, you are saving more number of patients. That is more important. So that's the reason one whole session I have taken for ST elevation. Not the carrying a message is another message is you should not diagnose ST elevation every patient because you are panicking the whole community. Not all ST elevation are due to ST elevation MI. There are several reasons for it, like a pericarditis, early repolarization, LBVB is there. You can have many LVH will be there. ECG remains a very good diagnostic tool, but must be correlated with typical chest pain. A patient comes with a health checkup, young age, 25 years, athletic build, and comes with a bradycardia and atypical chest pain. ST segment appears to be elevated and J point is elevated and concavity upwards. You diagnose me as a benign early repolarization syndrome rather than an acute MI. So clinical history is very important. And if it is not correlating, then your diagnosis is wrong. So go by the clinical history and take the ECG correlation according to clinical history. There are certain characteristics like the magnitude of the ECG, morphology of the ECG, width of the QRS complex, and secondary forces, left ventricular forces. Everything determines the ST segment rather than only acute MI. So everything, look into every aspect and take a call. So ST segment elevation is very important, but diagnosing is also very, very important. So this class is only dedicated for ST elevation. After this, I have to have a feeling everywhere, whenever you are putting the ECG in the for discussion, everybody should commit, whether it is convexity upwards or concavity upwards, background history, and from there on diagnosis. So my whole aim of the class is to ensure that everybody are diagnosing the ECG properly. Thank you for the patient hearing. I'll stop sharing. If there is anything in the chat, I'll be more happy to answer. I'm allowing you to unmute also. If you want to ask question also, you can ask question. Otherwise, you can put it in the chat box. For the next 5-10 minutes, you can have a discussion of whatever you want.
Sir, excellent lecture, sir. I have one small question, sir. Without
Please, sir.
ST elevation, only T wave inversion, isolated T wave inversion, sometimes we have a doubt, sir. In that scenario, what is
the T wave will be later on. See, I am just, we have completed P wave, we have completed PR segment, we have completed QRS. Now I come to only ST segment.
Okay, sir. Thank you.
Yeah, ST elevation, the next class will be on ST depression alone. Then T wave. So every segment of the ECG can be discussed, and every segment will have a carrying of message. And at the end of all the individual segments, everybody should be in a position to discuss and read the ECG completely.
Thank you, sir.
Thank you. If there is no more doubt, means we'll end the session. But only thing, every time we put a ECG, everybody try to commit on that. So that the commission of your ECG, after few ECGs, you will also master the whole ECG. As simple as that. So ECG is evanescent, volatile. Now you will understand everything for the next one day. The next subsequent days, you will find the ECGs is much difficult. So once you start committing, it becomes much easier. So I will request everybody to commit yourself for the diagnosis. Since there is no more questions and nothing is in the chat box, okay, I'll just wind it up. Thank you very much.